Hi, everyone. Thanks for taking the time this evening to join us. So we've got a few people here at the moment. I think what we'll do is we'll probably wait 3 or 4 more minutes, see if the numbers increase a bit more, and then we can crack on from there. All right. Okay, fine. So I think we'll do some introductions for now. So that will hopefully give us another minute or two, and then we can crack on with the questions. So, hi, everyone. Thanks again for joining us this evening. So hopefully you've been to some previous sessions with us, but we're part of the MedTech teaching series, and we're currently doing a road to final series covering, apologies, we're covering various specialties leading up to finals. And a lot of the content is still relevant to, exams in earlier years as well. So hopefully there's more than just final year students here. So today we're doing neurology. Just a quick introduction. So I'm an F1. I'm currently working at the Norfolk and Norwich, and I've personally done a neurology placement as my first one. So I know bits and bobs, but definitely not as much as a lot of my seniors did. So, but I have some tips and tricks and hopefully some inside things that will help not only for your finals, but for the job as well going forward.
Hi everyone, my name is Haz. I'm also an F1 based in Stoke. I've not done a neurology placement. It's more just revising around the topic to just teach you a few things about it. And yeah, please do message on the group chat. I'm happy, we're happy to answer questions. Don't feel like you have to ask it at the end. So yeah.
Lovely. So this is a timeline of what we're covering. So the neuro session today, obviously, and then we have a few more coming up. So hopefully some of those will interest you and you'll be joining us for those as well. Format of the session, so these will be the main topics that we'll cover today. We'll go into a bit more depth for the higher yield topics, less depth for the lower yield ones. And there are some other ones under the neurology list that you'll see on the MLA that we've kind of left out here because they're not purely a neurology focus and there's an overlap with other specialties. So these are the ones that will mainly get treated by the neurology department. Okay, so for each of the questions, you'll get a minute. So I'll start the timer when you see the question, and then we'll go through the topic itself, and then we'll come back to the question and just discuss how you should be thinking about it and some of the key parts to the question. All right. So everyone get your brains into gear. We'll start with question 1 now. All right, so that's the minute. So we'll carry on and we'll have a look at the topic. So topic revolves around stroke and TIA. All right. So stroke, as I'm sure you all know, is focal neurological deficit and is presumed vascular in origin, and it lasts over 24 hours. So that's the key differentiation between TIA and stroke. And as I'm sure you all know, the etiology will either be hemorrhagic or ischemic, more likely ischemic, much more likely, so 85% of the time. So just looking at the etiology for the two, just bear in mind that for a hemorrhagic stroke, it's treated by stroke if it's intracerebral, so it's within the parenchyma. But other things like subarachnoid, subdural, extradural, often the patients will come to the neurology department within the region, but they will then be referred to the neurosurgery department in the wider region, or if there is one in that hospital. And they will often either say that it's for treatment surgically, or it will be treated conservatively within your own neurology department. Bear in mind that hemorrhagic strokes are more commonly due to hypertension, and other causes of non-traumatic hemorrhagic strokes. You have vascular malformations as well. So these are somewhat common, and brain tumors, vasculitis too. Risk factors, I'm sure you all know, but hypertension is a big one. After a hemorrhagic stroke especially, you really need to try and manage that. Even after an ischemic stroke, because you have areas of ischemia, damaged cells, they're at risk of, or the vessels nearby are at risk of rupturing and leading on to a hemorrhagic stroke after the ischemic one. So stroke presentation, we should all know, acute in onset. You have the facial droop. Limb weakness is a big one. Dizziness, not so much. It depends on which region is affected. Coordination of balance, again, related to which part, but we'll look at the anatomy shortly. All right. So thinking about the vessels, so we have the circle of Willis here. And so the anterior ones, they arise from the carotid arteries, and then you have the ones in the posterior circulation. Those come from your vertebrobasilar arteries, so in the posterior chain. So you need to be aware of which parts of the brain are affected. So I think a slightly nicer picture here. So the anterior circulation typically affects this territory more. MCA is more lateral, and then your PCA at posterior. All right, and you need to know the Banford classification. This is particularly important on the wards as well. Often, so it's more so clinically guided, this Banford classification, and it doesn't really change the management all too much, whichever type of stroke it is. But it's used to classify ischemic strokes. So the main categories that you need to think about: unilateral weakness, so that can be the face, arms, or the legs; homonymous hemianopia, so visual field loss on the same side in both eyes; and also higher cerebral dysfunction. So that's various things, but the most common ones will be dysphasia, so that's affecting speech; dysphagia, so that's affecting swallowing. And just a nice way to remember that. So dysphasia with an S, S for speech; dysphagia, G for gagging. So swallowing is affected. You can also have visuospatial dysfunction as well. So the anterior circulation. So what you need to think about in terms of the presentation of which part of the brain might be affected is the cortical homunculus. So the anterior cerebral artery affects the part of the motor cortex it's predominantly involved in controlling the legs. So it supplies the lateral parts of the frontal, temporal, and parietal lobes. In terms of the associated signs, it's more so going to be looking at the wrong slide. So yeah, it'll be the lower limbs more so than the upper limbs. So that's important, and you'll often get behavioural changes with that as well. So your middle cerebral artery, so this is what affects the frontal, temporal, parietal lobes. And in this case, you get the upper limbs affected more than the lower limbs. And you can get aphasia or dysphasia as well, and quadrantinopias as well. So this I won't go into much depth now, but I think we'll cover this when we do the ophthalmology session more so. Thinking about the posterior strokes, the cerebral artery strokes, so this mainly affects the occipital lobe. And with this, you can get contralateral homonymous hemianopia. So when you see these sorts of visual signs, then you're thinking more so posterior circulation. And you have agnosia as well, so difficulty in recognizing familiar objects or faces. And yeah, it can also affect balance as well. So that's another one that you need to test in patients. So here you have your hemianopia, but again, we won't discuss that in much depth today. So with your posterior circulation strokes, just think Danish. So you're thinking about your cerebellar signs. So the Danish covers the dysdiadochokinesia. Patients will have ataxia, nystagmus, intention tremor, slurred staccato speech, and hypotonia. And if you've not done a neurology placement, you'll actually find it's quite a nice one because you do often see quite a number of these signs. So it is quite textbook. So yeah, as part of the posterior stroke, you have your posterior stroke syndromes as well. And the one that we'll focus on in a bit more depth is Wallenberg, or lateral medullary syndrome. And with this, so there's a list of things, and I haven't really got a memory device to memorize it, but just remember the list for this. So they'll often present with nystagmus, they'll have vertigo, Horner syndrome on the same side that's affected, and facial sensory loss on that same side as well. But just be aware that you have your stroke mimics as well. So various things that you need to test for. So hypoglycemia is a big one, so you need to rule that out. Bell's palsy, so it's a CN7 palsy, and often you have the facial droop and stroke, which is also because the CN7 is affected. But just remember, upper spares upper, so upper motor neuron is stroke will spare the forehead, so the upper part of the head, and then the lower motor neuron, so the bells, will have that affected. So you usually just get the patient to try and raise their eyebrows to try and differentiate that, obviously, before you do any investigation. Space-occupying lesions, another type of stroke mimic, especially if there's some sort of compression. All right. Investigations-wise, so this is often done on the front door, so an ED, but you need to get a CT scan urgently, so within the hour, and make sure it's non-contrast. And the reason we do that is more so to rule out a hemorrhage. So often you won't see any sort of change or ischemic changes within the hour, but you will often start to see some sort of ischemic changes within 24 hours. So look out for the ischemia. And yeah, so this will be hypodensity, so it will be a bit darker compared to the hemorrhagic stroke, which will be a bit brighter, which signifies blood on the CT. Another score that's used, so I think this is important for your exams as well, is the NIHSS score. You don't need to know it in too much depth, but just be aware that they do a score for patients when they come in, and you then repeat it within 24 hours and then after a few days as well. And it's a good way to kind of monitor the patient's progress. And hopefully you should see improvement if you've done something like thrombolysis or started aspirin. Just some other investigations that you need to consider as well. So do the glucose to rule out hypoglycemia. Using these, you want to rule out any sort of electrolyte imbalances like low sodium. It's important to do an ECG as well, because AF is a big cause of an ischemic stroke. There we go. And yeah, that's a really important point there as well. So a normal CT doesn't rule out an ischemic stroke. So either you would do an MRI quite soon after, or you can repeat the CT a bit further down the line. Both will show areas of ischemia. So we've already kind of discussed this in terms of the investigations. As for the management, so if it's an ischemic stroke, within the first 4.5 hours, you want to thrombolize the patient, typically with IV alteplase, after which you then start the patient on aspirin 300 milligrams for around 2 weeks, or for 2 weeks, and then after which you would convert to clopidogrel, and you would give that for lifelong. And just remember the numbers, 300 and 75. So 300 aspirin if you're giving the high dose, which is usually in the first 2 weeks, and then 75 for clopidogrel. Some patients will also get dual antiplatelet therapy, and that's just based on the severity of the stroke. But for exam purposes, I wouldn't worry, because even when you're actually on the ward, even that's just kind of up for debate, and it just varies consultant to consultant. All right. So further investigations and management. So the MDT is particularly important. So you have your swallowing assessment. So obviously patients might have dysphagia. So aspiration pneumonia is something that you need to look out for. Make sure that they have VTE prophylaxis, but if they're on a DOAC already, you don't really need to give them anything like an apixaban on top, unless they have atrial fibrillation. So if they have atrial fibrillation, then you want to give them a DOAC, at which point you wouldn't need to give them any VTE prophylaxis like dolteparin. Yeah, so you have your various MDT members, so you have the list there, but we can give the slides out after for you to look into that in a bit more depth. So you can do a CT angiogram as well. If you're suspicious that there's a larger vessel occlusion, and this is particularly important for patients who you think will be candidates for a thrombectomy. So you'd refer them to interventional radiology for that. So again, this really depends on the ward, but some consultants will always do a carotid Doppler, and you're looking for a carotid artery stenosis, and anything that's greater than 70%, they can be referred to the vascular team for an endarterectomy. Secondary prevention is important. So for an AF patient, so this isn't strictly correct, sorry. So it should be a DOAC for prophylaxis, but again, it might vary based on trust. And if the patient isn't on AF going forward, you would start on aspirin initially, and then you can switch to clopidogrel after 2 weeks. Lifestyle is really important, so discussing that with patients. And then thinking about the hemorrhagic stroke. So if it's intracerebral hemorrhage, so as we discussed, then it's treated by the stroke department. So in this case, it wouldn't be for neurosurgical evaluation. Apologies, this slide is more relevant for when we look at the other cerebral bleeds. And so, yeah, thinking about a TIA, so this is, you have stroke-like symptoms, but it resolves within 24 hours. And yeah, you can use the ABCD score to estimate the risk of stroke. But typically, if it's something that resolves within 24 hours, then it's likely to be a TIA. And in terms of managing it, you still need to give the patients 300 milligrams of aspirin, and you give that stat. If it presents within 7 days of the episode, you also need to have a specialist review within 24 hours. Anything after 7 days, they need a specialist review, but you can delay it slightly. And for secondary prevention, again, with these patients, you still need to put them on clopidogrel 75 lifelong, because they're at increased risk of having an actual stroke down the line. Give them statins as well, and again, blood pressure control is important, preventing the risk of a hemorrhagic stroke. Okay, so looking at the question, the key is that they have these stroke-like symptoms. So speech becomes slurred, they drop their books, they have this weakness, facial drooping, but then it resolves within 20 minutes. So for this patient, because it's a TIA, you need to start them on 300 milligrams of oral aspirin. Okay, so we'll do the next question. So again, you have a minute, and then we'll discuss the question after. Okay, so that's the minute. So we'll go through and discuss the condition first. So Parkinson's. So the condition, so you have chronic progressive neurodegenerative condition, and that is caused due to a loss of dopaminergic neurons in the substantia nigra. So this should hopefully be buzzwords that you're aware of at the moment. In terms of the key presentation, it usually starts with this unilateral tremor, and then it can progress bilaterally. You have cogwheel rigidity, and then you have this postural instability, which is because of a postural blood pressure drop. Thinking about the pathophysiology, so you have your substantia nigra, and so so it's important. So it's in the basal ganglia, and this is important because usually it's involved with inhibition of muscle tone. So when it's affected, you have this increased tone, hence the cogwheel rigidity. It coordinates slow and sustained movements. And so you have a loss of coordination with these patients once that's affected as well. So moving on to the presentation, as we discussed, so you have bradykinesia, so slowing down of the movements, and it becomes less coordinated. So you have this ataxia as well. Resting pill rolling tremor, and this is usually quite classical. You actually see them kind of rolling the pill. So it's quite textbook. And as we mentioned, you have the cogwheel rigidity as well. And with these patients, you'll have this postural instability, a shuffling gait, and you have this mask faces as well. So Parkinsonian mask. So differentials are very important. So Parkinsonism is the overarching condition, but if it's idiopathic in origin, then it's called Parkinson's disease. It can be drug-induced as well. So several medications can cause that because they all cause a reduction in dopamine. So you have your antipsychotics, some antiemetics, lithium, methyl dopa as well. And the other one to be aware of are your Parkinson plus syndromes, which we'll look at very briefly now, but it's not the most high yield thing for your exams going forward. So the key one to be aware of is dementia with Lewy body. So you have this early onset of dementia, and you have Parkinsonism symptoms as well. And it's important to realize that the dementia usually comes before the Parkinsonian symptoms. And you also have these visual hallucinations, which aren't as classical in Parkinson's disease, and also change in consciousness, fluctuation consciousness. So they might become quite delirious as well. Progressive supranuclear palsy. So just think about the names. You have supranuclear, and then you have this palsy as well. So with these patients, you test their vertical gaze. If they're not able to move their eyes superiorly and they have this palsy, then it's quite a key sign. Multisystem atrophy, so you have really profound autonomic dysfunction. So particularly this postural hypertension, so a big drop in their blood pressure when they stand up. And then those patients are really, particularly quite unstable. And also they're more likely to be incontinent of urine as well. And it's more severe in presentation. So those three are the main ones, but again, we'll send you the slides. You can have a look at the last one, which I won't go through for the sake of time. So in terms of the management of these patients, so the MDT is very important. And so pharmacy-wise, so levodopa is the most effective medication that you can give. And it often provides patients good control for the first 6 to 10 years, after which it becomes less effective. So it's usually given as cobenfy because it's given with another medication, and both of them together. So the other medication prevents the breakdown of levodopa in your system. So cobenfy is often given, is how levodopa is given. You can also have dopamine agonists as well. So ropinirole is an example. But the main one for the sake of exams you'll need to know is just your levodopa or cobenfy. All right. And so if it becomes very severe and patients are refractory to medication, so once you've tried one type of medication, you can then give another one as an adjunct. But if it becomes really severe and refractory medication, there is something else you can do more surgically, which is deep brain stimulation. So that's when you place these electrodes on the basal into the basal ganglia, and the aim is to kind of resolve things, but patients after are typically very off their baseline, and it's more so just to prolong life as opposed to being curative. The other thing that kind of overlaps is the tremor. So because the tremor or the pill rolling tremor is the key sign, it can be confused for an essential tremor, especially in the older population. So an essential tremor is very, very common. Family history is a key aspect of it. And patients will more so have a bilateral tremor, but just be aware that in Parkinson's, bilateral is if it's drug-induced Parkinsonism. So that will always be the case, or it can be more severe Parkinson's that's progressed from unilateral to bilateral. So that's not the only sign with an essential tremor to look out for. The main thing to look out for is patients on movement will have a worsening tremor, whereas in Parkinson's, it will more so be when they're resting. So if you distract them with something else in Parkinson's, then the tremor worsens. Whereas in essential tremor, you'll ask them to do the finger nose test, for example, and as they're reaching out, the tremor gets worse as they reach out. It improves with alcohol. But what's key is that you don't really get other neurological deficit with it. And in terms of the management, propranolol is used first line, and that's what that will usually settle things for most patients. You can add another medication, primidone, as well, but it's often given as an adjunct or in place of propranolol, but there's not as much evidence for it. So looking at the question, so the key points here were that it's a 50-year-old patient, the tremor is bilateral. So again, not the main way to differentiate between essential tremor and Parkinson's tremor, but nonetheless relevant. So it's been for a number of years, fine. There's a family history, which can also be the case for Parkinson's. But again, the key difference is when he's outstretched his arms, the tremor worsens. And in terms of the next step in management, starting on propranolol was the correct answer. So we know it's an essential tremor from the presentation, but another key area is that it greatly limits the activities of daily living. So with some patients, there might be certain things that trigger the essential tremor. So it might be psychiatric, for example. So you can, if it's not as severe and it's not really limiting their daily living as much, then you can maybe think about reassurance and trying to resolve those triggers first. But because this is quite troublesome for the patient, you would just start them on a trial of propranolol, which should usually work for most people. Differentiating the two, fine, so we've covered that already. So we'll have a look at the next question now. So again, you have a minute on the board, and then we'll go through the question after. All right, so that's the minute. So we'll have a look at the topic now. So this is more so the types of brain bleeds that aren't in the parenchyma. So let's start with extradural hematoma. So this for this the etiology is that you have a rupture of the middle meningeal artery, and so you have this collection of blood in the space between the dura and the skull. And the key etiology for this is a head trauma. In terms of the epidemiology, obviously it can happen to anyone, but you typically see young patients who've gone through some sort of trauma, like a motorbike accident is quite a common one that you'll see, or a sports injury. And just be aware that with these patients, you'll often see some sort of skull fracture as well, alongside the bleed. So that's something to be aware of. In terms of how it presents, so you'll have this trauma. Patients usually have a loss of consciousness, and then they have this interval after where they're a bit lucid, they're not quite themselves. And if it gets particularly severe, if there's any sort of compression, they can get these, and particular swelling, then you can get a raised intracranial pressure. For that, it would be more of an emergency. In terms of the investigation, so you need to do an urgent non-contrast CT head. So any sort of bleed, whether within the parenchyma or not, you need to do that as an investigation. In terms of how to remember it, so extradural starts with an E. So I always just think egg-shaped. So that's how you can differentiate it on a CT scan. You might follow up with an MRI after. That's if there's any sort of doubt with what you think the differential is. And as for management, again, for these ones, you just contact the neurosurgical department and they choose whether to treat it conservatively, or whether they want to treat it on their end, so they can use craniectomy or Burhol for that. The next one is the subdural. Just be aware that you can have both acute subdural, so that's within a few days, a chronic subdural, so it's a bleeding that's been present for over 3 weeks. Subacute, so that's in the middle, so 3 or 4 days to 2 to 3 weeks. And then you have acute on chronic, so a patient who's had a chronic bleed, and then that bleeds even further, or there's recurrent bleeding, that can then cause more of an acute presentation after. So with this one, you have the bridging veins that are affected, and that causes blood to collect between the dura and the arachnoid layers. Risk factors, again, for this and all of them, it can be due to trauma or falls. These patients usually are more so the elderly patients who have slightly weaker veins, so more likely to tear the bridging veins. Alcohol is a big risk factor as well for these patients, and for any sort of brain bleed, prior use of anticoagulation or current use of anticoagulation. And just be aware, the trauma may have happened a while back, so that's thinking about more of a chronic subdural hemorrhage. So in terms of the presentation, this is more of a progressive presentation. It's less acute, so you have this gradual continuous headache. And with these patients, they might have fluctuating consciousness. They can be confused. The personality can change. And again, if there's sources, particularly large bleed, then they can get compression, signs of raised ICP. In terms of the way to remember the imaging, so subdural is like slide. So you see this kind of banana or slide shape on the lateral part of the brain. So again, refer to neurosurgery, but we've had our surgery talk, I believe, so I won't go through the options in much depth here for that. You have your subarachnoid hemorrhage as well, and so that's bleeding into the subarachnoid space. Key etiology to be aware of is rupture of an aneurysm, and a key risk factor for that is polycystic kidney disease. So it's important to think about the patient's past medical history for that. But the main cause of a subarachnoid hemorrhage is trauma as well. And again, that can be in any patient age group. For the presentation, so we should hopefully know this, you have the thunderclaps, very severe headache, and often the pain will be in the back of the neck and kind of lead back of the head and lead a bit further down the neck. And for this, you get signs of meningism as well because it affects the meningeal layers. So you have photophobia, neck stiffness as well for that. Investigation. So again, do an urgent non-contrast CT head, and aim to do it as soon as possible. But you'll only often really see findings within the first 12 hours. And if it's been around 24 hours, or sorry, if it's beyond 12 hours, then you'll have a bit of doubt. And so if you can't see anything on the CT, then you would refer them or do a lumbar puncture with the neurology department. And there, what you're looking for is to see if there's any blood products in the CSF, and that would cause presence of oxyhemoglobin and also bilirubin. And you would see this kind of straw color. So you'd be able to see it when you do the lumbar puncture as well. So yeah, the name of the test is you do a xanthochromia. Managing it. So ignore that. So this is the one that you refer to neurosurgery for. And yeah, so if it's particularly severe, then they might need to go to ICU. But neurosurgery will often deal with it. Just be aware from a pharmaceutical perspective, nimodipine is given for these patients as well. That reduces the risk or delays cerebral ischemia. Complications to be aware of. So patients can have rebleeds, spasming, so vasospasming, and this can then lead to a secondary stroke. Hydrocephalus as well, as you can with any sort of stroke or brain bleed as well. And SIADH is unique to subarachnoid hemorrhage as well. So you need to be cautious of their sodium levels. Looking at this one, so this is a younger patient. They've had a fall. So they've hit the left side of their head. They lose consciousness quite soon. And then you have this lemon or egg-shaped hemorrhage in the parietal area. So the age group you're thinking, the loss of consciousness as well. And then the key thing here is that it's egg-shaped or lemon-shaped. So you know, therefore, that it's an extradural hematoma, and that the etiology is the tearing of the middle meningeal artery. All right, let's have a look at the next one. So again, you have a minute on the board, and then we'll discuss it after. Okay, and then we'll have a look at the next question as well. So again, you have a minute for this one. All right, so let's go through the topic. So meningitis. So this is when you have inflammation of the meninges. It's typically infectious in nature. And just be aware that one of the main causes is bacterial. So you need to know the possible organisms based on the different patient age groups. But I won't cover that in much depth. So you can take a screenshot or we'll send the slides after as well. So you can have that for your notes. You can have viral meningitis as well, but this is often less severe. It's self-limiting, so you don't really need to manage it other than supportive care. You can have fungal infections too, and that's more so in the setting of HIV or patients who are immunosuppressed. So the main species to be aware of is your Cryptococcus neoformans and Candida species. And also you do see TB meningitis here and there as well. So we'll go through some of the LP findings, which will be important for differentiating the type of meningitis. In terms of the headache, so you have the classic triad of headache, neck stiffness, and photophobia. Be aware of the two signs. You don't really see them tested much on the wards, but from an exam standpoint, this is particularly important. So you have Koenig's sign. So this is inability to fully extend at the knee when you flex the hip at 90 degrees, and it's limited by pain. And then you have Brzezinski's sign as well. So when you flex the patient's neck, you get this spontaneous flexion of the knees and hips. And it's all just because the meninges going down the spinal column are just kind of irritated. Patients will often have a fever as well and feel quite nauseous too. The diagnosis, so initially there's a clinical suspicion and you start patients on an antibiotic. And so specifically that's IV ceftriaxone is first line. If there's any sort of clinical doubt and you're thinking more so a meningoencephalitis, then you will also start them on an antiviral. But with the antivirals, because there aren't many side effects in that regard, and it's better to be safe than sorry, often you see a lot of people at the front door just start both because patients, because it is very distressing, even if it is just meningitis, and that in itself can cause a bit of distress. And you might be suspicious that the patient isn't quite at their baseline or behaving as they normally would, which would make you more so think an encephalitis. But we'll discuss that in a bit more depth shortly. Definitive. So you want, in terms of the diagnosis, you want to do a lumbar puncture, and you usually do a CT as well. You just want to rule out something like raised ICP, which is important before you do the lumbar puncture as well. The different results to be aware of. So appearance to start with. So for all of them, you'll see this kind of cloudy or turbid appearance, aside from a viral, which is colorless or clear. Protein, for a viral one, it can be normal or it can be raised. But for a bacterial, you will typically see it raised. And then the glucose for viral will often be normal, whereas for bacterial, you'll more so see it reduced. And yeah, the predominant cell type is important. So bacterial is neutrophil, viral is your lymphocytes. And yeah, just be aware. So TB has a very similar presentation on the results to a viral. The main thing to be aware of is the cloudier appearance. And the glucose is more likely to be reduced, but normal in viral. So encephalitis, so this is when you have inflammation of the brain parenchyma as opposed to the meningeal layers. And again, it's commonly due to an infection. And the infection is often secondary to infection from organisms, so local structures. So it might be like an ear infection, for example, or throat infection. And it can be non-infectious as well. So especially in younger patients, you often do an autoimmune encephalitis as well screen. So you would send bloods off for that, and you can check for autoimmune causes as well. And yeah, the most common viral organism is HSV, to be aware of for that. So in terms of the presentation, it's slightly different. You don't really get the signs of meningism as much, but it can happen. And So the key presentation, they'll have this fever, they can have a headache, but the main thing to be aware of is that they can have behavioral changes, and they can have this sort of confusion as well. So differentiating it, the key thing, so doing a lumbar puncture for one helps, but from a clinical standpoint, if there's suspicion of both, then it's deemed a meningoencephalitis. For the diagnosis, so you do an LP for patients, but you also do a viral PCR, which would then pick up a possible virus. You do an autoimmune screen, so you send off bloods for that. So there's various ones that you can send off, like Casper2, anti-NMDA. Imaging for these patients as well, if you're thinking another possible cause. And you do an EEG for some patients with doubt, where there's doubt as well. Especially if it's an epileptic patient, they might just be post-ictal, causing their confusion. In terms of managing them, so you need to treat with IV acyclovir if it's viral in origin, but if there's other possible causes like paraneoplastic or autoimmune, then you can start them on steroids. So looking at this question, so this patient is coming with photophobia, neck stiffness, they have quite a high temperature as well. But there's a bit, you're not 100% sure on what's going on because they're quite confused because they're not orientated, and they're not quite their normal selves. So there's a bit of doubt. It could be a meningoencephalitis, but in the first instant, especially if you're on the front door, then you would want to start these patients on IV Kef, Trioxone, and acyclovir. And then the neurology team thereafter, they can kind of decide which one to continue with once they've done the LP as well. AMG, so you'll see that more so in gastro or gen surge conditions. IV ceftriaxone alone, just because of the confusion, you would want to start an acyclovir, especially because there aren't particularly severe side effects from it. Dexamethasone is an important addition once you're confident or you've confirmed a diagnosis of a bacterial meningitis. So that's usually after you've done the LP. You also want to start on dexamethasone. So it wouldn't apply in this case because we're not 100% sure whether it's bacterial or not. Urgent CT head, you might do, but the key differentials here would be meningitis and encephalitis. So there's no need for an urgent scan in that regard. Sorry, so apologies. Let's go back to, so for this question, where is it gone? There we go. So you want to start the patients on oral ciprofloxacin. So that's your, so for family members of patients, you want to give them prophylactic treatment. If you think it's a meningococcal meningitis, so slightly more severe, then patients or family who've been in close contact with the patients, you want to give them prophylactic oral ciprofloxacin. So that's a classic question you'll see. All right, so moving on to cord compression. So I'll quickly give you another minute for this. Okay, so we'll have a look at the condition. So cord compression. So this when you have injury to the spinal cord. and causes of which include trauma, so that's more so in younger patients, or if there's an elderly patient, you're thinking a tumor. So it might be one that's metastasized from elsewhere, like lung or breast, or hematological. Key one to think about is multiple myeloma. Patients might also be osteoporotic, and there's a fracture which might be causing the cord compression. In terms of the signs and symptoms, patients will often present with limb weakness. They usually have this upper motor symptoms below the level of the lesion. And at the level, you see this lower motor neuron. So I won't go through the pathophysiology now for the sake of time. But they can often have sensory symptoms as well, which includes back pain, which is a key sign, and autonomic ones as well. So urinary retention, constipation as well. Key investigation to do that's important for definitive diagnosis is your MRI spine. Often the whole spine is done because it's quite, from a clinical standpoint, it might be difficult to kind of focus just on one particular area of the spine, so they often just do a whole spine. You might also do a CT, and you can do lateral x-rays if you're thinking malalignment, if it's due to a fracture. From a blood standpoint, you can do tests for multiple myeloma, which includes electrophoresis, if you think it's a hematological malignancy, and bench-Jones proteins to cover that as well. So cauda equina, so this is when you have compression, and it's usually due to disc herniation, a compression in the spinal canal. And with these patients, you get symptoms like back pain, reduced anal tone, so you need to do PR exams, saddle anesthesia, and positive Babinski, so they have these upper motor neuron signs. Radiculopathy, some impingement on the nerve roots past the spine. And so, yeah, here you get the lower motor neuron signs, but I won't go through that for the sake of time, but we can give you the slides after. So the key investigation for this patient was an MRI whole spine. So that's key for a definitive diagnosis. So very quickly, we'll do this question as well. And then, so you have a minute for this one as well. Okay, so we'll move on. So this question is about the differentials for a headache. So we'll start with primary headaches. So this includes tension headache, cluster headache, migraine, trigeminal neuralgia. I think for the sake of time, just because we are going over quite a bit, I'll just discuss the main condition after that was relevant to the question. But you're welcome to take a screenshot. So I use this as a resource for my finals. I thought it was very helpful. And it kind of summarizes all the types of headaches. So here you have your primary headaches, the secondary ones, so thinking more intracranially. So that's that. So if you want to take a screenshot. And lastly, you have the secondary extracranial causes as well. But for the sake of time, we'll quickly move on. So the answer to this question, so you're thinking a young patient with a higher BMI and they're female, idiopathic intracranial hypertension is something you should think about quite quickly. And the fact that they're also on the combined oral contraceptive pill. And again, it's a very common condition that you do see. So that was the answer in this case. All right.
Okay. I'll start my questions now. Make sure we'll try and finish on time. So I'll give you another minute for this question, and then Mem will tell me when to start explaining when the minute is done.
So that's the minute there.
Cool. Okay. So let me just talk about epilepsy treatment. So it's quite clear from the case that it was epilepsy. So this is how you go about, treating it. And actually, these guidelines, I think they're fairly new, as in the last couple of years. So when I was revising for finals, I think these had actually changed when I did neurology in third year. So you tend to not give any medications or pharmacological interventions after the first episode. When a patient has their first seizure episode, they go to the first epilepsy or first seizure clinic. That is to investigate for other causes of epilepsy or causes of their collapse. But in certain situations, you may start it after the first incident. So if there are obvious signs of neurological deficit, there's brain imaging associated that is the neurological cause. An EEG can also be part of it. And then also if there's a strong family history or the family or patient is very keen to actually start on medication. So I don't have any fancy rules to actually remember a lot of these treatments, but we can go through some of the medication. So general tonic-clonic seizure. So that is when you get a stiffening and then you get a jerking. And that was actually in this case. So for men, you give sodium valproate, and women, you give lamotrigine or levetiracetam. The reason why is sodium valproate is teratogenic. So therefore, in women, you give lamotrigine, especially women who are childbearing age. Then for focal seizures, those would be your frontal lobes, your temporal lobes, occipital lobe seizures. It would be lamotrigine's first line, and then second line would be carbamazepine. Absent seizures, that is when patients will go blank. They may not be speaking, and actually they don't even necessarily remember that they had an absent seizure. They may describe that they were lost in the room or unable to catch up where they were, but that's what they would do. So you give ethoxosumixide. I'm butchering these pronunciations. And then for men, it'd be second line sodium valproate, and women is lamotrigine. Myoclonic seizures, that will be just jerking. That you give sodium valproate, and then levetiracetam, and then tonic or atonics, and that's just stiffening, and the patient would just fall to the floor, stiff. Again, men sodium valproate, women lamotrigine. So if we go back to the question, the answer is lamotrigine. So it's clear in this one that it is a tonic-clonic seizure because fell to the ground, very stiff, and then had rapid jerking rhythmically. Now, it does technically say that this patient, whilst is childbearing age, is 26, but is not planning on having any children anytime soon, starting a family. You still look to give lamotrigine, even though it's because it can have some fertility effects on you. So that's why you still go for that. And then also, if the patient was then to, after 5 years, come back and say, now I would like to have children, it can take time to reestablish a new medication, and then start then to prepare for a family. So that's why you would just start on lamotrigine there and then. Okay, so hopefully that's explained. Please do put questions in the group chat if you have any. So I'll give you another minute for the next question.
One minute there.
Okay, so let me start explaining. So this case was myasthenia gravis. So that is an autoimmune condition where you get a dysfunction in your ACH receptors. So ACH receptors are actually all over the body, generally cause sympathetic stimulation. But in terms of remembering signs and symptoms, it's fatigable symptoms, fatigability. So these would actually be, the patient generally would be fine in the day and actually get worse at the end of the day or worsening of it. So common symptoms is extraocular muscle weakness, double vision, proximal weakness in the face, the neck, limb girdle, and that can present as like stroke type symptoms. So it's something, it's one of those stroke mimics, and you may need to think about, not diagnosing stroke, think about this. Ptosis and also dysphagia, difficulty swallowing. So in terms of investigations, there's a number of things you need to do, and you need to read the question carefully about what it's asking for. For a definitive diagnosis or initial investigation, if that's the question, single fiber electromyography, and it has a very high sensitivity. There are other things to investigate for. So thymomas are very common in patients with myasthenia gravis. So you need to do a CT thorax of that, and if so, maybe surgical intervention to remove. You need to measure creatine kinase levels, just because this can somewhat mimic rhabdomyolysis, but in these patients, it would be normal because you're not getting a breakdown of muscle. And then also you can do antibody testing like acetylcholine choline receptors. In terms of management for these patients, we're going to split it to long-term and then acute problems of myasthenia crisis. So long-term is pyristigmine. That's a long-acting acetylcholine esterase receptor inhibitor. Therefore, it's just to increase the activation, increase acetylcholine in your system.
Sorry, everyone. I think Haz may have logged out, or lagged out, rather. Are you still with us?
Hello, can you hear me?
Yeah.
Oh, fine. Okay.
Perfect.
Cool. I'll just carry on. So, management, pyristigmine can be used for long-acting. It's a long-acting acetylcholine esterase inhibitor. So, therefore, just increase the activation of these receptors. In terms of myasthenia crisis, so that is where, because these receptors are all across the body, it would actually affect your respiratory muscles, and therefore you can get respiratory depression. It's normally triggered by stress or infection or an acute problem, and these are medical emergencies that you need to give plasmapheresis and IV immunoglobulins. So we go back to the question. The answer is B. So you could tell that this is myasthenia gravis because it says it in there. But in terms of the management, this appears to be an acute episode. Now I understand it says respiratory distress, increased work of breathing. Typically, it is actually respiratory depression, so difficulty in breathing. But normally in the acute phases, you get like an overactivation of the body, but then later you get this depression. Is triggered by a response, whether that's an infection or stress. He said, patient had the flu last week and was generally unwell since then. So that's the trigger for the myasthenia gravis, because you get an increase in metabolic activity or requirement of ACH. So that's why the answer is not E, and that's why it is B, because this is an acute scenario. Okay, so we can do the next question. You can have a minute to have a read, and we'll go through it together.
So that's 1 minute there.
All right, so we'll go through it. So in this case, it was multiple sclerosis. That is a demyelination of your central nervous system, the neurons. So it can affect sensory and motor responses. In terms of diagnosis, it is 2 or more relapses differentiated by time, place, and time and space. Okay, and we'll go through that. So there's different forms of treatment for MS. You got acute relapses. That is when someone's very unwell, and then you give high dose steroids for 5 days. It can be IV or oral. And then in terms of your long-term management, you've got disease-modifying drugs. They tend to be used in autoimmune conditions. So a lot of these medications are monoclonal antibodies like natalizumab and acrelizumab. And then also treating for specific problems are known for MS. You got if a patient complains of fatigue, you give amantadine. Also, mindfulness and CBT can also be given. Spasticity is a common question, so you give baclofen or gabapentin. Bladder dysfunction, self-urinating catheterization, you can also give oxybutynin. So that would be that's MS treatment. Also, actually, I'll explain that when we go through the answer. Okay, so in terms of the answers, the answer is A. So technically, all these things you would somewhat do, but let me break it down. It is MS. The way you tell it is this patient's coming with neurological symptoms, 12 hours of history of lower limb paresthesia, but then also he explains that two similar episodes in the last year, as well as other incidences as well. So that's MS, and it's almost these unrelated symptoms, but unrelated neurological symptoms. You're thinking MS, okay? In terms of the management, there seems to be an acute episode that this patient's going on of this lower limb paresthesia, and it's spreading. So therefore, we need to treat this immediately. Do an urgent neuro referral, but it's not the first thing. Repeat brain MRI and spine. It could take time for that, and it's very clear from this that this patient has got an acute acute relapse of the MS. So it's not needed right away, but you will do it eventually. And then B and C, those are long-term management for MS. So that's why the answer is A for this case. Okay. I'll give you another minute for this question.
1 minute.
Okay, let's go through this case. So it was raised intracranial pressure. So raised intracranial pressure, that is a medical emergency. There are different reasons why you can get it. It could be any of your intracranial bleeding. It could be a space-occupying lesion, abscess formation. Yeah, I mean, abscess formation, that can somewhat also be associated with meningitis as well, that we talked about previously, cyst formation. So there's a number of causes for raised ICP. In terms of how does it present, headache, vomiting, reducing level of consciousness, and also swelling of the optic disc. You also get this classical Cushing's triad. So it's a common question that I like to ask in finals. So you get widening pulse pressure, bradycardia, and irregular breathing. And those are like, boom, this is raised ICP. In terms of investigations, you would do an urgent CT head. Then later you do an MRI, but CT head you can look for like, gross or major pathology. And in terms of management, and this is about reading the question carefully about what to do immediately and then what to do later. So immediate or conservative things is head elevation of, then medications. IV mannitol is there to reduce the cerebral edema or osmotic diuresis that's going on. And then you got something called controlled hyperventilation. I've not actually seen this before. Because you're ventilating, you're blowing out CO2. That causes vasoconstrictions of your cerebral arteries, and as a result, that reduces your ICP. You can also then, once you got there, you look for treat the underlying causes. Repeated lumbar punctures can also be done. We can talk about that when we go through answers. So if we look at the answer, the answer is D, IV mannitol. Okay. Acetazolamide is tend to be given for idiopathic intracranial hypertension, your obese female with all the similar symptoms, but probably less acute. IV dexamethasone can be given in like somewhat replacement for mannitol. It can reduce edema, but mannitol, it tends to be the first line. Urgent lumbar puncture, that can be done, but it just depends on what the cause is at the end of the day. Also, it can be contraindicated, but if patients got like these headaches, then urgent lumbar puncture would be contraindicated. Also, it can take time for that to actually be done, whereas IV mannitol is a quicker thing that is. So yeah, hopefully I've explained that. Okay, we can go for the next question. I think this is the last question of our session, so I'll give you another minute.
One minute there.
Okay, so let's talk about mononeuropathies. I don't really have a great way to remember this. I kind of like learning about this because I've an interest in hand surgery or plastics. So the way is I think about, I don't know if you guys have done your OSCEs, but I think about when I'm doing my OSCE examination, what the things I'm looking for, and why I'm actually doing, rather than just random, hand and arm movements. So let's just try and break it down, and it's just pattern recognition at the end of the day. So radial nerve, you get if a patient presents with a fracture at the shaft of the humerus, if you look at your anatomy, your radial nerve kind of goes across there. That could be associated with that. Wrist drop as well is associated with radial nerve or extension. So wrist drop is kind of part of that. You get a problem with that, or they're not able to extend their fingers. So that's how I remember radial nerve. Common peroneal nerve, I think of it as the extensor hallucis longus, which is your big toe. So you get problems with your big toe. So dorsiflexion, eversion, also your big toe plays a part of that. Your anterior tibial and peroneal nerves, they run on the dorsum surface of your foot. So, okay. Ulnar nerve, you get the claw hand. So ulnar nerve tends to, supply mostly your fourth and fifth fingers. So you get that claw finger shape. You get it to affect your hypothenar muscles. The hypothenar muscle hand is these smaller muscles that are on the base or underneath your fourth and fifth finger. And then your thenar muscles is the big chunky one that's at the base of your thumb. And then you get radial deviation as well. Okay. Median nerve, I feel that's easy to remember. That's carpal tunnel syndrome is compression of the median nerve. So that'll be wasting of your thenar muscles, the big muscle underneath the base of your thumb, pronation of your hand. You get ulnar deviations opposite to ulnar nerve, positive Fallon's and Tinel's test, and thumb opposition as well. So that's a bit easier to remember. Axillary nerve, that's part of your brachial plexus. It supplies classically essentially loss in the patch of your deltoid muscle. Also, if you get a fracture at the head of your humerus, I kind of think of axillary because it's near the armpits. You get armpit-ish near symptoms. And then other ones, I've seen these on PassMed. Traction injuries, so hanging off roof with hands. So these are, let's say handymen who are, up on ladders and then they've accidentally caught themselves and fell off the ladder. They would get these traction injuries in the C8 and T1 region. Erb's palsy is common in macrosomia, or when you have, larger babies being born via normal births. They can then, when they're birth, they get these arm hanging loose and problems with pronation, and the arms immediately rotated. And then the last one, intercostal brachial artery. So that is a problem that is very much associated with breast surgery and breast reconstructive surgery, where you get a loss of sensation in your armpit. Okay, so there is no great way to remember it at the end of the day. It's just pattern recognition. So in this case, the reason why it's ulnar nerve is wasting of the hypothenar muscles that we said. It's underneath your fourth and fifth finger. Finger abduction is also associated with it. So that's why it's ulnar nerve. When they give these questions, they don't write down all the things. So let's say you've remembered claw hand for ulnar nerve. Unfortunately, they may not write that. So do try and remember. I've tried to explain verbally the main points to remember the different mononeuropathies.
Perfect. So that rounds things up. So again, thank you so much to everyone for taking the time out this evening to attend this session. Really appreciate if you could just give us some feedback. So I think I've posted it in the chat. In return, you'll get a certificate for attendance as well. So it'll help us tremendously for our applications going forwards. So thank you so much again. Again, we have several different sessions left for the series. So please do come to those as well. So they're usually on Thursdays at 7, but we might do an additional one on the Tuesday if it's relevant that week to the talk that we're doing. All right, so I think we'll leave it there for this evening. So thank you again, everyone. If we could just complete the feedback forms, that would be amazing. So the slides will be uploaded onto the medal with the video, I believe. You're very welcome, blessing. So thank you for attending. So the slides, we'll upload with the medal. If there's any sort of technical issue or it doesn't come through, just message us on medal and then we can send it to you directly as well. All right. Perfect. Enjoy the rest of your evenings. Thank you, everyone.
Cheers. Thank you, everyone.